Hello, my name is Michael Hartung, and I am an abdominal radiologist at the University of Wisconsin in the United States. I will be talking about the principles that make for a great radiology report, which will not only benefit the patients and ordering provider, but also importantly will benefit you and increase your enjoyment of practicing radiology. So let's get to it. I'd like to first acknowledge the collaborative nature of this material and express that I'm greatly appreciative of these likely familiar individuals who have helped refine the ideas in this talk. In the material that follows, a few disclaimers are in order. First, what I'm presenting are guiding ideas and principles, but they're not rules. Every institution will have regional preferences and nuances that influence reporting styles, and success is simply to get people to think about how to improve their reports. Here's a quote from literature that also applies to radiology. And what it's really getting at is that we have these pet phrases or terms that we often use and hold dear, but we need to take time to evaluate if they're actually communicating what we intend, and if they do not, to be willing to discard them. So let's start by looking at an example report. In much of our reporting, we can convey more information with greater clarity using fewer words. So in this example, a good deal of the words that are included largely amounts to filler or fluff. And while there may be some stylistic reasons to include some of these terms, much of what's included can be removed and distilled to an essence, and stating it with that essence provides clear communication. So this first impression contains a natural sentence structure that, despite conveying simple ideas, is kind of difficult to wrap your head around and requires some degree of translation to apply the information clinically. As you're reading it, you might be thinking, okay, so things are worse and there's new small effusions, right? So that can be revised with that same amount of information stated in a much more succinct fashion: worsening multifocal pneumonia with new small effusions. This new impression is easy to understand and apply clinically, and there's really no reason to surround this clear idea with unnecessary fillers that make it more difficult to understand. Here's a similarly long impression containing unnatural sentence structure, which can be distilled into a straightforward phrase: enlarged left adrenal metastasis. And it also includes some additional information that might be helpful and of interest to the ordering provider. So impressions like this are memorable in that they don't require translation. It can be read out loud during morning rounds or to a patient during an office visit, and we're basically giving them information they can readily act upon clinically. It is direct, so if we can say things in a direct manner, it is best to do so. So don't shy away from simplicity of language for fear that it might appear unsophisticated. And finally, an informative report is one where we anticipate the questions a reasonably curious person might ask after reading the impression. So in this case, it would be totally natural to ask, how much bigger is it and compared to what date? And so you anticipate those next level questions, and you can include those in your impression to show the ordering provider that we really care and that we're really trying to interact with them and the patient in a more profound and clinical way. In this talk, we're largely going to focus on our communication with the ordering provider. But it's also important to acknowledge that the audience of a radiology report is actually quite diverse, has different needs, and has different levels of understanding, which makes our job very complex indeed. So the ordering provider is looking for a clear assessment with specific recommendations, but we also use our report for ourselves to organize our thoughts as a sounding board, to be technically complete, and to have a complete evaluation. We might be thinking about other radiologists who will be reading up on our reports and following up what we said. We're thinking potentially about subspecialty providers who want fewer specific recommendations and might be looking for relevant surgical or staging information. Patients have increasing access to the reports and are looking for language that's understandable, not particularly specialized and without ambiguity. There's billing and coding considerations, there's research interests, and also medical legal concerns. In addition to the diverse audience of the radiology report, there's other elements of the nature of radiology that make clear reporting difficult. So first, in contrast to radiology, in the way they interact with patients, most specialties don't have to be right away. So they'll interact with a patient over a timeline where they can modify or adjust their assessment based on new information, changing clinical parameters, or new test results. Radiologists, on the other hand, have minutes to make an accurate assessment. And so we're uniquely put in the position of making a final assessment based on imaging findings in a single point of time, often without the benefit of the clinical or laboratory information. And as a result, if we're wrong, our mistakes are publicly documented. And this can create a lot of stress and uncertainty and insecurity about our reporting. So what impact do these stressors have on reporting specifically? So there are some subtle and not so subtle ways that this can manifest, but in general, there's a tendency towards avoiding synthesis, using non-committal wording, or having a lack of clear recommendations. So one thing that can happen is radiologists can avoid making an assessment altogether. So how that manifests is restating the findings in a technical way without providing any sort of synthesis or differential diagnosis. So calling, for example, a 1.5 centimeter indeterminate left lower lobe nodule, but not stating much beyond that. It's tempting to use excessive qualifying language. So for a clear diagnosis like acute appendicitis, we were tempted to say findings are most suggestive of acute appendicitis. Shifting responsibility back to the ordering provider can come in many forms, but one of the most common is recommending clinical correlation without really thinking through specifically what should be correlated or if there even is any sort of meaningful correlation to make. And finally, recommending vague or overly aggressive follow-up. So may consider follow-up if clinically warranted, which really doesn't provide any clear parameters, or recommending a very early follow-up where for a low clinical suspicion scenario. So this must be a new problem, right? Well, not according to the radiologist Dr. Enfield in 1923 when he described the makings of a bad radiology report. So he talked about the radiologist describing in detail all that they see but not telling what they think about it, and that such a report tells much yet almost nothing. So it sounds like restating the findings and avoiding clinical synthesis and application is not really a new problem, and it is one that will continue to impact radiology. And that makes sense because we're talking about different level tasks here. On the one hand, stating findings is something that we teach to early level trainees, and we expect them to gain some competence in just being able to describe what they see in the imaging. But making a synthesis to the level of a diagnosis or differential diagnosis with appropriate recommendations is the highest level of clinical activity that a radiologist participates in, and is really an advanced level skill. So how can we get there? How can we improve our reporting? Well, there's a simple but extremely important step to take to improve your confidence and begin to overcome the anxiety-provoking aspects of our job, and that is to follow up our cases. So let's be honest, most of us don't do this, and some of us may never do this, but avoiding follow-up disconnects us from reality and isolates us from the clinical impact of our reports. And as a consequence, over time, we become more interested in being radiology right than clinically relevant. So, for starters, for follow-up, be sure to follow up your cases in a PHI-compliant format. So, for example, MyPax has a built-in follow-up function that I use to flag studies and set reminders. Other people I know use a secure spreadsheet, and hopefully you can find a system that suits you. So, a couple ideas for when you should be following up cases. So when you're unsure of the diagnosis, when you recommend additional imaging, invasive procedures, biopsy, or follow-up for an incidental finding. So all of that might seem like a lot of work, but let's go into the benefits in greater detail, and hopefully I can convince you of just how valuable follow-up is in improving your confidence with reporting. So what can follow-up do for you? There are some major benefits here. So first of all, it can tell you when you're right. And finding out that you're right can help to build your confidence, and being appropriately confident is really important for making great reports. It also can tell you when you're wrong. And while humility can often be painful, it's a really important part for us for learning and identifying weak areas that need improvement or patterns of mistakes that we make that need to be remedied. It gives us topics for targeted learning. So there's nothing as motivating as a clinical context to apply knowledge to, and that's also a very important memory aid. So I find targeted learning to be the most rewarding learning that I do right now, and follow-up can help to provide those cases for that. It makes the patient our teacher, and it also makes the provider our teacher. So we really kind of open ourselves up to learning from both patients and other providers. It increases our connectedness. So it helps us to identify our value on the team and also helps us to identify areas of communication breakdown when things that we might feel we're stating clearly are overlooked or misinterpreted by the treatment team. And finally, it increases our empathy. It shows the real impact that we have on real patients with our reporting and gives us a sense of how much anxiety unnecessary follow-up exams can create, unnecessary procedures, and so on. So now that we've established the importance of follow-up, let's hone in on reporting in more detail. So first, let's define the major sections of the report. So the findings section can be thought of as the complete, accurate radiological description of all the abnormalities with pertinent normal observations. So the emphasis in findings is on short, informative, and factual phrases. And the impression is the meaning of the findings, which leads to a diagnosis or differential diagnosis and recommendations for further management. So these can be thought of as what is seen with the eyes and what matters to the brain. So it is tune-up time. I will now address the findings and impressions separately and focus on a few high-yield areas. So we can divide our thinking into stylistic and content areas, and under style, we will focus on avoiding terms of perception and avoiding redundancy. So the first item is about overuse of terms of perception. It is very natural to use them because by nature, we're talking about what we see when we dictate a report. Looking at these two examples, you'll notice that the first one actually has two instances of terms of perception, which can be distilled into the following: multiple small renal cysts. The second example unnecessarily states that the small bowel loops are visualized within the abdomen, which we hope the reader would know, and that can be simplified as multiple dilated small bowel loops. So there's two major reasons why a heavy use of terms of perception is unnecessary. First is that your perception is already assumed when you dictate the findings. This is particularly relevant for structured reporting in that the header is basically providing a root sentence structure. So liver colon can be thought of as stating the following findings are present in the liver. And that the second is that they unnecessarily elongate our reports and often take away from readability, especially because radiologists struggle enough with brevity and tend to use unnatural sentence structure and phrasing. So I would encourage anyone to take a paragraph from a typical report, notice how many terms of perception are used, and see what it looks like and how it reads after editing most of them out. I find that it makes a big difference. The second stylistic area for tune-up is to avoid redundancy, which also has a lot in common with what we just covered because terms of perception often quickly pile on to make reports redundant as well. But this outlet involves making comparisons, and you'll notice that they really start to pile on when you look out for them. And I think a major reason for this is that many of us, when we're dictating reports, we're actively thinking, and that unavoidably will create redundancy. So this first example about multiple liver masses, you can imagine the radiologist first seeing the masses, starting to talk about them, then pulling down comparison studies, and then making an assessment. But removing these redundant phrases results in a very straightforward sentence structure that quickly answers the clinical question and leaves no room for ambiguity. So this does require withholding a comment into the dictaphone until we have a little more to say than that we see something, and that can be challenging to do, but I hope you can appreciate the difference it makes for simplicity and clarity. Similarly, for the second example, we can remove the redundant phrasing and simply state that there's an enlarged right renal mass. So when you're making a comparison, more does not make merrier. Just pick one and move on. That wraps up the style, and now we're ready to move on to content, which will include saving interpretation for the impression, giving incidentals a proper burial, and keeping it organized. In this contents category, one thing we commonly do is to blur the line between the findings section and the impression by repeating partial or complete impression statements in both. So for this first example, there's focal thickening of the transverse colon, and then we start to give a differential for that. In the second example, we start to talk about some equivocal findings in the gallbladder and start making recommendations for further evaluation. There is a tension here where it's natural to begin to process and synthesize the findings while we report them, but the problem is that it creates unnecessarily long, repetitive reports, and there's an increased risk of internal discrepancies as changes may need to be made to both the findings and the impression. So both of these can be heavily edited to simply state the findings in a much more factual manner, removing the synthesis. And This is particularly helpful for trainees to avoid, while the attending radiologists may more commonly focus on editing the impression rather than digging through all the findings and revising that as well. An area of great frustration for many radiologists is reading a study that we do not feel is indicated. So here are some examples of unnecessary follow-ups that I have read. And while it's been frustrating to read these studies, a major part of this falls back onto us for being non-committal and not providing a clear assessment of something as benign and requiring no further follow-up. There is an important exception to withholding interpretation in the findings section, and that is for so-called buried findings that you do not intend to discuss in the impression. So there's nothing terribly wrong with the following examples, except that a non-radiologist would be unlikely to know what to do with them, and they can generate patient anxiety, as many internet searches for terms like these will include some mention of the possibility of cancer, even though we personally do not find these things suspicious at all. So if you think something is nothing, do everyone a favor and just call it benign or of no clinical significance. So we can take these low attenuation renal lesions, likely cysts, call them cysts, call them benign lymph nodes, and call them benign bone islands. So here's an objection. How do I know for sure that something is benign? So the assumption here is that being ambiguous somehow provides legal protection or helps the patient in some way, but in reality it does not. We have a responsibility to make a clear assessment of radiology studies, including clear recommendations. So while this may feel uncomfortable at first, making assessment will get us out of this vague, ambiguous, non-committal middle ground, which essentially shifts the responsibility back onto the lap of the ordering provider to figure out what to do with an incidental finding, even though they don't have expertise in radiological interpretation. So the great part of splitting these findings into the let it go or something should be done category is that it will promote radiological competence for all parties and help teach providers about what really matters in our studies. So we're now on to our last content area of the findings, and it's largely a practical one. I have certainly been guilty of dictating these rambly paragraphs and have often wondered, could there be another way? And the answer is yes. So we can look for opportunities to convert complex, long paragraphs listing multiple masses, collections, nodules, and so on into simple lists, which will facilitate communication to the treatment team and other radiologists who read the follow-up studies. And who knows, you might be reading your own follow-up and thank yourself. So taking these paragraphs and distilling them to these lists has some basic anatomy, which includes what item you're talking about, how you may define your dimensions, and if there's a comparison, and then you can talk about size, location, and comments. So the best way to get in the habit of doing this is actually to somewhat painfully revise your own rambly paragraphs into lists, and then that helps to reinforce this concept and will help you to prospectively identify opportunities to use it for future studies. All right, so now we're on to the impression. And here we're going to similarly look at ways to improve both the style and the content of the impression. For style, we will discuss avoiding technical language and leading with the favorite diagnosis. Avoiding technical language may seem easy or a straightforward thing to do, but it's actually quite challenging. And that is because you just spent your time dictating the report using technical language, and it's what's on your mind. But the impression is a communication to non-radiologists, and they're not trained in technical radiology terms. And spoiler alert, they're not interested in them either. So the biggest offender that I have found is signal characteristics, and often involving MRI and ultrasound. And rambling on about these features leads to risk of misunderstanding or diluting the central message of the impression. So in both of these examples, we're using MR and then we're using ultrasound characteristics, and we're starting to talk about being concerned about cancer, but it's actually quite hard to extract that from these impressions. So when we remove the signal characteristics and clearly state what we're concerned about, we're sending a clear message that we're concerned in the first case about some residual viable tumor and exactly where it is, and then that we're concerned about a new liver lesion concerning for metastasis, including an appropriate recommendation. So something that I have found helpful is to try and state the impression in a similar way that I would when speaking on the phone or with an ordering provider or presenting it in a multidisciplinary conference. In these settings, I find it easier to cut to the chase and state things as clearly and succinctly as possible, and that's precisely the sort of language we should be using in our impressions. So we would never say something like this on the phone or in a conference, but we would say something like this. And approaching that sort of clarity of language is what we're going for in our impressions. This second stylistic tune-up point makes such a huge difference, and that is to lead with the diagnosis. A way to think of this is stating what you think is going on as quickly as possible, rather than building up to it like a punchline or arguing your way to its inevitability by piling on a list of findings to support it. Remember, you've already supported your diagnosis in the findings section, and you don't have to do it again. Looking at both of these examples, the straightforward diagnoses have a risk of being lost in the lengthy surrounding details. So instead, cut to the chase and say what you think is going on up front. The reason why this makes such a difference is that the impressions that start by jumping into detailed findings are likely to overwhelm the reader with seemingly stray facts and little provided basis for understanding them until you mention a specific diagnosis. When you lead with the diagnosis or a favorite diagnosis, you're anchoring the impression and providing a context for the reader in which they can understand the relevant findings that follow. So you're basically saying, here's what we might be dealing with, and then you're giving them important supporting details. So that wraps up style. Now we're on to content, and we're going to discuss the importance of avoiding clinically insignificant observations and making clear recommendations. It can be challenging to know what to include in the impression or what to leave in the findings, particularly during training, but I think we've all come across unhelpful shopping list type impressions that detail nearly every passing observation that the radiologist makes. In this case, it is easy to overlook the fact that there's an ovarian mass that needs to be worked up while you're lulled to sleep by this rambling list. Aside from diluting the important diagnoses, these types of impressions also create unnecessary patient anxiety and inappropriate follow-up examinations that we talked about earlier. So I think the conflict of what to include and what to omit can be approached in a simple way. If you don't want the ordering provider to think about it or act on it, don't include it in the impression. Sometimes I try to imagine the ordering provider calling me to ask about something I'm potentially going to include in the impression. And if I find myself saying, well, actually, it's nothing, no, you don't have to worry about it, then that's a good reason to omit it. Our final area of content tune-up focuses on recommendations, and this brings together a lot of important concepts. Recommendations are a major way that radiologists take responsibility for a study and advance patient care. So consider, nobody will have greater insight into the study than you have. Nobody will take more time to interpret the study. And you have the responsibility to provide a complete evaluation and clear recommendations. There are key questions that can help guide the formation of the recommendations, and what it really boils down to is giving as specific or direct advice as possible when you can. So one might object to this and say that specialists are offended with direct recommendations, and certainly that might be true in some institutions where they prefer just to have the facts. But at the end of the day, they are free to ignore our advice and do what is best within their expertise. And really, if we follow up on our cases, it will become much, much better at giving appropriate advice that aligns with their typical management. On the other hand, not giving clear recommendations carries a much greater risk for harm and confusion, as in general, providers are very appreciative of us helping them to know what are the appropriate right next steps. A helpful variation of the impression that some practices have adopted is including a separate recommendation section. So this can be particularly helpful when you have a multi-point impression with separate recommendations. This can create for a very confusing report and result in the risk of something important being overlooked. So here we have an impression with multiple incidental findings that require different workup by different specialties potentially. And it's very confusing when you read this report and you're saying, okay, so what exactly do I need to do? And so breaking it up into a separate recommendation section helps to outline a checklist style approach for the ordering provider to address. And if you read their progress notes, you'll probably realize this reflects the same way that they think about a patient during a visit as they write their problem list. So we're essentially delivering information to them in a very clear and helpful format. A major benefit to providing clear recommendations is that it helps to circumvent some of the inherent ambiguity of the terminology that we commonly use to convey various degrees of certainty. So this is from a paper that studied how our terminology conveys diagnostic certainty and shows just how miserably radiologists and non-radiologists agree on terminology. So anything under 0.4 is basically not agreeing. And so the only phrase that we really agreed on was diagnostic of, and everything else had very low agreement on the scale, even phrases like consistent with, highly suggestive of, most likely, and compatible with. So people have attempted to create certainty scales and assign percentages of certainty to different phrases, and that very well might be a helpful approach, But I also want to advance the idea that our recommendations give weight to how serious we think something is, and they are a major way that we can modulate the perception of our levels of certainty surrounding a diagnosis. So you can think about the differences between recommending a 3-month follow-up and a 1-year follow-up, follow-up imaging versus more immediate or urgent biopsy, or recommending urgent intervention or consultation. In this final section, I'm going to propose building blocks that are particularly applicable for challenging cases that do not fit neatly into a category and require some nuanced discussion or consideration. So this is a proposed template for working through these cases. You start with a favored diagnosis. You can say suspected or likely based on how confident you are about it. Key findings supporting that diagnosis, I find myself using the phrase evidenced by quite often. Reasonable alternative diagnoses, and then recommendations for reaching a definitive diagnosis. So it's kind of complicated just to look at it in bullet points, but we'll take on some examples for application here. So this first example, we're talking about a colonic mass and we're concerned that it's cancer. So here's how we could communicate that. Suspected adenocarcinoma of the transverse colon, and we that's our favored diagnosis, and the key findings are circumferential mass. Ischemia and inflammation are reasonable parts of the differential, but they're felt unlikely given the amount of soft tissue thickening, and then GI consultation with consideration for colonoscopy and biopsy to reach a definitive diagnosis. Something that I have found helpful that I use in this example is it can be a platform for acknowledging a differential diagnosis, but in the context of why you don't think it's likely. So here I'm acknowledging that infection is a reasonable consideration as an alternative to this suspected infiltrative neoplasm, but that I don't think it accounts for all of the findings. And this is a way that you can anticipate what the ordering provider or subspecialist might think and address it directly, give weight to your concern about the imaging findings, and in a sense you're saying, don't be fooled into thinking this is just infection. I think it's more serious and needs to be carefully managed. A final variation of this theme is to start with the disease category and discuss the subtypes as part of the differential. So here, there's clearly diffuse enteritis, and here are the key findings are bowel wall thickening, mucosal serosal hyperenhancement, small amount of ascites. And here in the second part, when I'm talking about the differential, I kind of get into how severe I think. So there's very severe involvement, and I give a relatively broad differential of potential causes. And then at the end, I left recommendation for gastroenterology evaluation again. So the reader is not going to be left wondering if this is a bad case or not, and is going to have some good ideas for the differential to work through. So some departing principles to guide you on your way. So learning to report is not like learning a fact. It's not a box that we check during training, but it's a continual work in progress that will require your careful attention throughout your career. And finally, I find it really helpful to strive to create the sort of thoughtful, thorough, and responsible reports that I would want for the care of a close friend, a family member, or even for yourself. And with that, I thank you for your attention and for attending this conference, and I hope that you found this talk helpful.